Welcome to INP4. This video will be focusing on the topic of pain management of the perioperative client. Don't worry if your Moodle shell that you're looking at doesn't look the same as this Moodle shell. That shouldn't be an issue, as most, if not all, of the documents I'm going to be looking at in this video should be on your current Moodle shell. If any of them are missing, please let me know. So before we actually get into the PowerPoint, it'll actually be helpful to go through some of the individual documents. The first one I'm going to go through is a little scribbled up diagram I made on excuse me, on spinals and epidurals. So a spinal or an epidural, typically these are a combination of anesthetics and narcotics. Or it could be purely anesthetic. And sometimes when we talk about PCAs and that, sometimes it's purely narcotic. The point is that we want to limit pain. So when you see the patient on the unit after surgery, the main purpose of the epidural or the spinal, well, the spinal's worn off by then, but the epidural or the PCA will be primarily pain control. But in the actual OR, there might be larger amounts of anesthetic running through the epidural or having been given through the spinal injection, because you actually want to inhibit movement as well. So I'm going to go through a document about the specifics on that in a minute, but first I just want to show you a little bit about what an epidural or a spinal is. So with that kind of preface, let's just kind of look at a quick review of anatomy and physiology here. So here you've got a very, very rough diagram here of, here's like the spinal column. So these are your nerves. These are the nerves of the central nervous system running down the spinal cord. Then you've got these regions, which I know you've learned about in your A&P courses. And let's just make sure we label them clearly here so that you know what we're talking about. This is the subarachnoid space that surrounds the spinal cord. It's also called the intrathecal space. That's where the CSF is, bathing the spinal cord. Now, it's important to know the term intrathecal space because the intrathecal space and the subarachnoid space, one and the same thing. It's important to know that those terms are interchangeable, because when you look up medications in your Davis drug guide, one of the routes it presents to you is the thecal route. So if you're looking up an anesthetic, let's say, and it says, you know, the duration of this med is, let's say, 6 hours via the thecal route, that's T-H-E-C-A-L, thecal route, then you know what they're talking about is something like a spinal injection that is injected directly into the intrathecal space, otherwise known as the subarachnoid space. So let me state that again in a different way. When someone gets a spinal, they'll typically get it right before surgery. And if you go into the surgical suite, the OR, the operating room, you'll see them being held up or voluntarily sitting up on the edge of the stretcher or the surgical bed. And you'll see the surgeon or one of their residents injecting a single injection into this space, which is typically at L1 or L2. There's not a lot of choice there because it has to be below the spinal cord. You can imagine if you tried to make this injection higher up, you run the risk of hitting the spinal cord itself. Obviously, that would not be a good thing. So it's injected at L1 or L2, so you can expect to see like a little Band-Aid. You can expect to see a little Band-Aid when they come back from the OR at around L1 or L2, and that's where they've stuck the needle in, gone into the intrathecal space, and given a one-time injection of anesthetic, typically a mix of anesthetic and narcotic. So then what that anesthetic, so anesthetic being the real key word here, it's got to be anesthetic. That will go in there, and that anesthetic will bathe the intrathecal space at that level and beyond, and it might migrate a little bit with position, but basically will cause a loss of sensation and movement to that area for check your Davis drug guide, like it'll say onset, say 15 minutes, duration 6 hours, or peak may be unknown, duration 6 hours, right from your Davis drug guide. And so while they're in the OR, that part of their body will be immobilized and will not feel any pain. And then perhaps they'll get some kind of other sedation, either through a face mask or an IV injection or both. And they come back, but it's not a general anesthetic and it's not an epidural. What they've had is a spinal. And so when they come back, you'll see that Band-Aid in that space. Typically, by the time they get back to the ward, they've been in the PAR, the post-anesthetic recovery room, for a few hours. So it's pretty safe to say that in many cases, the spinal is almost completely worn off by the time they get to your ward. But you want to be sure that sensation has returned. So you're going to do something that's called checking dermatomes. That's something we'll talk about later in the INP class. But you'll need to check dermatomes. Anyways, that's a quick overall of the spinal. Again, it's a one-time, literally shot injection into the L1 or L2 space in the intrathecal region. The purpose of it is to cause numbness and loss of movement in that area for surgical reasons. And then when they get back to the ward, you want to monitor for the return of movement and sensation, especially. And for sensation, you'll do something called a dermatome check, which we'll talk about a little bit later. So that's the spinal. Now we move to something else, which is called the epidural. Now the epidural is a little different. It's a little catheter that's put in, kind of the same way like an IV is put in. It's not put into a vein. It's put into this region here called the epidural region. So they've gone past the vertebral column, past those bony prominences on your spine. Remember, these are the central nerves here of the spinal cord. And then in the epidural region, it's farther out, they'll have this, either they can do a one-time injection with an epidural, which I don't see that often, but it can be a one-time injection. But typically what an epidural is a continuously running infusion of anesthetic, or both anesthetic and narcotic. So typically it'll run continuously. And what it eventually will do is it'll eventually be absorbed past all these layers into the CSF, where again, it will bathe the nerves, having the same effect. Maybe it's numbness they want, but if they have an epidural on your ward post-op, typically it's just they don't want numbness, they want to control the pain. So they want the optimal level is they want the patient to have movement, they want them to have sensation, but they want to use the epidural to decrease the pain. Now, the issue with this is that the anesthetic could migrate. It could migrate up. Like, for example, if for some odd reason the patient went into reverse Trendelenburg position, the epidural medication could migrate up the spinal cord and start to affect respiratory muscles. It could even head on into past the brain, blood-brain barrier, and start causing a loss in consciousness. That's very dangerous. So you want to check for that kind of toxicity. And it's important that we're always monitoring with these things: the respiratory rate, blood pressure, level of consciousness, sedation rate, which we'll talk about again in more detail. But that in essence is the epidural. Now the good thing about the epidural is because it's in such an outer region, it can be basically inserted at any level of the spine. So there's a lot more flexibility with where you put the epidural in. Okay, so that's a quick summary or quick overview of epidurals and spinals. We're going to talk about PCAs more in the PowerPoint, but the difference between epidural, spinal, and PCA, one of the differences is that the epidural and the epidural and the spinal injection are going in through the vertebral column. They have to go through the vertebral column at some level, L1, L2 for spinal, and anywhere you want basically for the epidural. Although you wouldn't want to put the epidural too high because it could depress, your intercostal muscles. So within reason, but there's a lot of flexibility as to where it could go. The PCA, which is patient-controlled analgesia, on the other hand, will be going through one of the veins like an IV, exactly like an IV. And typically, you can typically it's going to be uh, narcotic going through the like hydromorphone or something. But you might see some variation on that. Just by the way, you can also get patient-controlled epidurals where they can control the infusion into the epidural by pressing a button. But I think it's enough for now. I don't want to over-confuse the whole thing. Just want you to get the basic essence and difference between a spinal, an epidural, and a PCA.